Good morning, everybody. So today I'm going to be presenting about the impact of patient-specific implants on delivery of patient care and outcomes. A little bit about me. My name is Blaz. I have multiple ways that I'll introduce myself, either as a storyteller, a waterman, a professor and practitioner of the kinetics of kindness, a risk technician, an innovator, a flow state junkie, and a deformity surgeon. And these are all intertwined in a lot of ways with one another, as we'll find out. Here are my disclosures, and a lot of these are actually relevant to this discussion, although with today, I'm gonna try not to be doing this as a branded speech or anything. And there's a bit of history with this too, if we look into sort of the whole sphere of surgical planning and sort of arriving at patient-specific implants. And this probably starts years ago with SurgiMap, which I think you guys use as a workhorse, and those of us with our DNA from the headwaters of San Diego Spine Foundation have been using this really since its inception. This ended up going on and getting picked up by NuVasive for a handful of years, and I worked on that platform to help with integration of cages and implants and so forth to help us arrive at deformity correction strategies. I later went on working with K2M and Stryker Spine, and they actually had a patient-specific rod years ago. It wasn't intentfully designed to achieve any other correction strategies other than the ones that you had chosen, and they had an in-house rod smoothing device that would temper that rod to how you chose. I worked with Medtronic on a task force for a few years where we worked with integrating technologies such as UNID, the robot, and a few other things into their suite of adaptive technologies. And that was a pretty interesting venture for me. And beyond that, I've worked with Carlsmed as a consultant, and I'm the co-chair of the Compass Data Registry, and I'm working with SMIO, and this has been sort of a 3-year work history for me. I was part of the initial US commercialization team, working with one of the other spine companies, working on sort of their software platform, planning strategies, and ultimately the deliverable of patient-specific rods here in the United States. So I'm gonna kind of park it at that for a moment. So this has really been kind of my wheelhouse for the past few years. And in this talk, I'm gonna kind of go over the following objectives, present some of these emerging technologies, and again, not as a paid speaker for them, but sort of as an end surgeon user. We're gonna go over UNID rods, the Aprevo implants from Carlsbad, and the SMIO platform. I'm going to discuss the rationale for patient-specific implants and discuss the impact of AI and ML on patient outcomes. And I'm going to do this through case examples. So I think you guys have some familiarity with the UNID platform at this point. So this is what they call their ASI, or Adaptive Spine Intelligence. And so if we kind of step back a little bit, we understand that, radiographic parameters are clinically relevant and continuously evolving. And this has sort of gone over the years from the SRS Schwab to an age-adjusted scale to the Rusali classification system, the GAP score. And years ago, when we first started thinking about this, we would go for these alignment objectives of a PIL mismatch less than 10, but that's actually a 20-degree variation between plus and minus, PT of less than 20 and an SVA of less than 5. And I think now many of us use the following objectives with a target lumbar lordosis of 0.6 to PI plus 30, a target L1 PA of 0.5 of the PI minus 20, and a target T4 PA within 4 degrees of the L1 pelvic angle. So this has been evolving. And some of the nice things about working with these platforms is as sort of the field evolves with our alignment objectives, they're sort of doing the work behind the scenes such that the algorithm is continuously growing and learning to sort of mirror what is kind of popular in the literature these days. So we know the clinical benefits of sagittal alignment. It's the most dominant radiographic predictor of patient outcomes. And so really when we go into a surgery, we want to hit our marks. When we think about key clinical issues, it's 2% of patients remain sagittally malaligned after surgery. Sagittal realignment and clinical outcomes are directly linked, and with the UNID platform, SVAs improved, 81% achieved normative SVA values, and significant improvement for all key parameters postoperatively. And this is sort of looking at a study below with Couros and Levesque, looking at sort of the comparison between historic patients and the number that remained corrected or malaligned versus that with UNID, and we're able to see that there was a demonstrable improvement in the reduction of malaligned patients after surgery. I'm sure you've all picked up a rod at this point in your fellowship or residency, and you understand that there's curve radii within the rods, and not one rod is fit for everybody. And a lot of times if you use a stock rod out of the tray, they come in a couple different varieties, high pelvic incidence or low pelvic incidence. And there's the age-old art of having your attending sort of, meld that rod to further to, what they think the patient should be at. And I think that's sort of kind of an old but incorrect way to do this. Machine learning prediction of thoracic kyphosis. So this is looking at 20 patients in the adult deformity world, instrumented from the lower thoracic to the pelvis to determine the ability of UNID ASI to predict postoperative pelvic tilt and thoracic kyphosis in the uninstrumented levels. And we see that there was a high p-value in the TK and in the uninstrumented levels. And so these findings suggest that surgeons could use this technology to consider the risk of PJK in the adult deformity cases. So the other thing that we encounter a lot is, rod fractures. And if we think historically, the rod fracture rate in deformity patients is about 9% or 22% in the PSOs, and these are drastically reduced in UNID rod cases. Now, when we think about, how good are we as surgeons at bending rods, we're not that great. So in this study, 10 experienced deformity surgeons were asked to contour rods using a French bender to 40, 60, and 80 degrees respectively, with and without a template. And we can see that when surgeons had a template, they were able to, within a high degree of accuracy, get these rods bent to the desired shape. So with the UNID ASI ecosystem, it's concierge. So they have engineers that'll help to simulate your surgical strategy. The AI-powered models will estimate the postoperative spinal compensation using predictive analysis, and patient-specific implants will be delivered to you to help achieve this. And I like to look at these as guardrails. So during surgery, when I'm doing temporary rods and so forth, I will actually take the UNID rod, put it in the patient, and see, how close I am to the mark that I need to get at. And so there's a couple phases to this. There's the pre-op, where we send images in. There's a planning phase where the engineers will interface with you. You can discuss what your surgical plans are. Once they kind of understand the strategies you use, if you're an anterior or all posterior person, they'll put up some suggestions of what you might do and what the spine might look like. And then there's the post-op comparison. And so this creates a continuous cycle of improvement with image analysis, case simulation, delivery of the patient-specific implants, data collection of your post-operative images, and it goes back into machine learning and back into the predictive model. And so this creates an iterative, virtuous cycle. Typically, when we get these cases, we'll send the images. There'll be a handful of different plans that you can choose from. You can directly interface with the software engineer and say, hey, in this case, I'm thinking about this, or maybe I'm thinking about that. And it'll help you kind of refine what surgical plan you wish to deploy. And this is old data. I think there's probably more than 10,000 surgeries right now. I know Chris Ames at UCSF has reached his 1,000th unit case. He brought that up in a recent conversation. And these rods come in titanium or cobalt chrome in 3555 or 60. And you can also get these in an MIS platform or tapered rod. And again, it's an industrial smooth bending process, so the rods aren't notched. Afterwards, you're able to work with your unit team to compare the pre-op plan and post-operative images and use advanced analytics and visualization of your outcomes to track your improvements. And typically what we'll do are meetings afterwards, and we'll go over cases and so forth and look at how I'm doing compared to plan. I'm going to go through a couple cases here. This one, interesting, I'd presented this one time previously at San Diego Spine Foundation, and Handy Malone texted me afterwards, and he's there like, geez, Blaz, you could write a thesis just off of this case. I'm going to kind of roll through it because I want to hit a few other technologies. But in essence, this was a 64-year-old female with a history of a high-grade slip at L5-S1. She underwent a remote gill procedure in L4 to S1 fusion. In 2014, she had adjacent segment issues, and somebody attempted to do an L2 to the L4 posterior instrumented fusion, but was unable to get access into the lower vertebra. So they bailed on that. In terms of her medical condition, she's got a variety of things, but nothing that was prohibitive of surgery. And there's her surgical history. In terms of her medication, at the time that she was referred to me, her morphine milliequivalents were quite high, almost in the 300 range. So that's a red flag for me. So a bit more of her spinal history. So in 2016, when she had seen another outside surgeon, he determined that she should probably have more surgery. And she underwent a T3 to the pelvis, and within 6 weeks she exhibited proximal junctional failure within a UIV +2 of 24.5 degrees and a T1 slope at 51 degrees. And she was parked there, so no further actions were taken. And her deformity progressed over the next few years from 2020 to 2021 with a 56-degree junctional kyphosis above her construct and quite a bit of anterior translation of her head. In 2021, she developed wound drainage at the cranial end of her incision with prominent spinal instrumentation. She was seen by neurosurgery at an outside facility, plastic surgery, and they did an IND, and they removed the upper instrumentation. She was placed on antibiotics and followed by ID, and she had rare staph epi in her wound. Ultimately, in 2022, she was referred to me at UCSD for management of her deformity. She was found to have worsening myelopathy, and if we look at the MRI over here, she's got quite a bit of stretch and ventral compression of her cord draped over the deformity. Her previous incision was well healed without complication. Her ESR, CRP were normalized, and she was cleared by ID for surgery. She did have diabetes, and her A1C was well controlled. So these were sort of the pictures that I got when she came in. Using SurgiMap again, I kind of modeled various corrective strategies for her. And at the T3 level, to me, that's a vertebral column resection, given the focalness of the deformity. And so then I kicked this over to UNID, and this was the plan that we came up with the rod template on the right with a 3.5/6.0 rod. And the big thing on this, I thought that was really helpful to me, was sort of the surgical strategy at this point. And that was a T3 VCR with parallelization of the paradjacent end plates and an anterior height of 27 millimeters. So with her, I took her for stage 1. I did exploration. I obtained cultures. I removed the posterior instrumentation from T5 to T10. Sent out for gram stain, culture analysis, and then I placed instrumentation from the occiput to T10. I did grade 2 osteotomies at multiple levels, and I put temporary rods in. I brought her back a few days later with bivector traction, deep irrigation, a T3 VCR with the said goals, using an expandable cage, and deformity heads at the levels above and below the VCR, just so I could use a 4-rod construct and untether this from the parent rods. And then I had unit rods run medial to the VCR rods. So this is her at stage 2, so she's in bivector traction. Another key thing about these is you put that chest pad way down on the belly, which really allows you to articulate the spine up here. She has the shoulder supports here, and again, bivector traction. And this is her after the VCR is performed. This is the inserter for the expandable cage. And then this is what the construct looked like prior to decortication and closure. Here she is after we got her closed up, and we can see now, the occiput is in alignment with her thoracic kyphus. And here she is post-operatively. So we avoided ICU admission. Her morphine milliequivalents went immediately from 240 to less than 90. She was neurointact. She was discharged home on post-op day 3 with her drains and the out-of-band dressing. She had an Aspen collar at all times, and she had a CTO when she was up ambulating, and we brought her in at the 2-week mark for removal of her dressing. And here's her pictures here. So I presented this case before, and I actually did present to her that there was a possibility of removing the occipital instrumentation, but at the time of the initial surgery, given the magnitude of the deformity, I wanted extra pieces of fixation to help get her head back over her hips, because sometimes like those C2 screws can actually pull out. And then when I reviewed her case afterwards and looked at her, there's almost like a superimposement of the unit rod on her post-op x-rays. And her analysis was, all clinical objectives were met. And here she is at her 6-month follow-up. And again, she had maintained all of her corrective parameters. I'm going to shift gears a little bit, and we're going to talk about a Prevo patient-specific implants. And I think you all may have had some exposure to them at Scripps so far this year. And so again, if we look back, there's a lot of complications with adult deformity surgery. 46% they have complications, and 26% require revision surgery, and malalignment is the leading cause of poor outcomes, and malalignment is achieved only 68% of the time. And so if we compare traditional stock devices versus a Prevo, on the traditional stock side, they're mass produced shapes and sizes. They don't fit the patient anatomy. They're not integrated into the overall realignment plan. There's minimal coronal correction. There's point loading on the end plates, and there's a lot of posterior, high posterior rod stress. Compared to patient-specific implants, they're designed and built for a specific patient at a specific level to actually fit and lock into the topography of the end plate. And within that, you can actually plan for deformity correction by increasing lordosis or coronal correction. And because of the increased contact area with the bone, it optimizes environment for fusion, reduces high stress concentration, and lowers the posterior rod stress. So I'm just going to skip over this. And these implants are available in anterior, lateral, and TLIF. And so if we think about end plate conformity, so when you take a regular stock cage and you put it in an inner body, there's a lot of space between the cage and the end plate. So there's a mismatch created with the cage end plate interval, and this causes point loading and so forth. So if we look at the anatomical interference provided by a patient-specific implant, these stresses are reduced on both the anterior and inferior, or superior and inferior end plate, from 31 to 66 and 35 to 69%. And you can see this on this stress scale here. So there's a lot of information being collected now on this. We've had a couple different things done looking at this. And so when we look at stock devices, missed target in the coronal correction by 7.1%. And when we look at custom devices at 0.4%, we look at undercorrection and lordosis in stock devices by 18.5% and 0.5% with custom devices. And we look at the posterior disc height, which if you overcorrect can end up causing nerve stretch, neuropraxia, overcorrection by almost 12 millimeters in stock devices within 2 millimeters in custom devices. So in 2022, this abstract was presented at CNS, and it sort of looked at the impact of those initial 67 Aprevo cases, and it was found that we were able to get people within near alignment with this device. Subsequent to that, this year we published 2 papers looking at the radiographic alignment in deformity patients treated with personalized interbody devices and the predictability of achieving target intervertebral lordosis using these devices. These are something maybe at some point we can do a journal club, so I won't beat this horse too much, but we know that within a high degree of the time, we're able to get patients within the desired lordosis range. And again, I think we'll probably save a further dive into that for a journal club, but I'll go a bit more into sort of how we do this and then a few case examples. So similar to unit rods, we send a scan, but we send a CT scan. The engineers and design team will look at these and work directly with the physician to make sure you're getting the levels treated, what your plan is, and then deliver an implant. And so this is a pretty seamless process. For me, it's just a button on my PAC system to push images, and then I usually will interface with my engineer team once a week or every other week, depending on my case volume. The implants are produced, delivered, and then we get post-operative analysis afterwards to determine how close we were with achieving our goals. So with the early look into this, they looked at 53 patients with 94 implants, and at all levels, the planned correction was achieved and maintained. And again, similar to the unit, this is an iterative cycle where we have a plan, you approve it, you put it, you implant this, you do the surgery, the data is collected, and it's put back into the system. So with anything with machine learning and AI, the more information that's put in, the more robust the outcomes will hopefully be in the future. This is a case example. It's not mine. It's just sort of an easy stock case, which you might get in the degenerative world, and it's looking at a patient who the surgeon planned to treat just one level, and we can see sort of the diagrammatic changes in the spine on the right after implantation. This is the production of the cage, and you can see sort of the unique topography of the implant. It's shipped sterilely, and you get one up and one down in size. Then we have, fluoro images in the OR, and then post-operative analysis where, the plan was achieved in this case. I'm going to go through this case real quick because I think I have another interesting one I want to look at. This was a guy with a bow type B and a significant sagittal deformity that I planned with unit throughout some various options to me, but at the base, really looking to achieve, 39 degrees of lordosis from L4 to S1, and then correction of the rest of the curve. So this was sort of this patient's plan. We ended up putting together this plan with unit devices, or with Carlsmed devices were made. This was sort of the modeling of this case. And then this was his post-operative pictures. So again, pretty happy with how things turned out from there to there and there to there. And then we did post-operative analysis. And again, to me, when I'm able to superimpose, the rod plan over the implant, I'm pretty happy with that. And we look at all the specific analysis. This is another case I want to go over, and this is looking at a unit Carlsmed case I did this year. This is a gal from Central Valley with a significant deformity, as you can see here. She has 70-something degree thoracolumbar scoliosis and significant kyphosis, and she's decompensated in both the coronal and sagittal plane. She doesn't really move but a few degrees from standing to supine, and her bending pictures compared to supine show, again, this is a pretty rigid but non-ankylosed deformity. Sending her to unit, I'll measure her out, get an understanding. This lady had also had a history of osteoporosis, so she was started on a bone anabolic agent prior to surgery to get her prepped. And then assessment, she's an adult idiopathic scoliosis with adult deformity with an SRS severe rating. She has decompensation in the coronal and sagittal planes, treated osteoporosis. And on her, the plan was suggested an L4 to S1 ALIF and a T2 to the pelvis posterior instrumented fusion with PCOs and a myocutaneous closure. So this was her unit plan right here. We can look at her parameters over here, where her mismatch were and what the plan was to get her back into alignment. And the big thing on her was that the TL measurement, the T10 to L2, and that was, she was at almost 60 degrees and get her down to 5 to be anatomic. This was her plan with Carlsmed, and again, looking to get her mismatch within reason. And then this is sort of my flight plan after stage 1 of the inner bodies, my 7D plan, and then the, my flight plan that I hang up in the OR for surgery. And this is her position on the table, so we can see like her severe kyphosis. So with her, she needs to be derotated, and this needs to be flat. That kyphotic section needs to be flattened out. And this is, what my ultimate goal for this gal is. So she had all instrumentation placed with 7D and PCOs performed with 7D. Temporary rods were placed with progressive reduction and selective compression distraction, in situ coronal bend and sagittal bending, and sequential derotation at the curve apex. And then again, like at this point, I'll lay one of the unit rods in to see how I'm looking compared to my plan. One by one, I'll swap out the temporary rods with the unit rods, finish the reduction in place with the final rods, and then the biologic strategy on her. I'll do intraoperative imaging. So this is her T-bar showing that I got her head right between her femoral heads. And then we'll look at things in the sagittal plane to reconcile that plan. This is her, she's being closed up and the final sutures are being put in place. And again, we can see like her on the table contours are greatly improved from before, really meeting up with what my expectations were. Afterwards, we do analysis with the Carlsmed team to see that, my objectives were obtained. And with her, 100% of the objectives were obtained for lordosis, the PILL correction, the disc angle and posterior heights, all with 100% obtained. So we'll do those analyses, and then our post-operative x-rays here, looking good. And, for me, my target L1 pelvic angle and T4 pelvic angle were within a few degrees of each other. So again, that sorted out really well for her. And then again, I can superimpose the rod plan over her rods on the x-ray. She was up and ambulating within 45 minutes of getting to the floor, avoided the ICU, discharged home post-op day 3, TLSO and ambulating. She had a bone stim on and continued on her bone anabolic agent. So kind of concluding my experience with these Carlsmed inner bodies, I will kind of consider using them if there's a significant loss of lordosis from L4 to S1 or fractional curve, and with a viable disc space that's non-ankylosed. I'll consider ALIF to restore sagittal angulation, restore foraminal height, posterior disc height, and horizontalize the vertebra on the coronal plane. If there's abnormal vascular anatomy or prior abdominal surgeries preventing me from doing an anterior approach, I'll consider TLIF I've done about 100 Carlsmed implants at this point, and I think I've probably done, I don't know, roughly 10 T-lifts. So in those cases, I will convert these to a T-lift. And also in the rigid non-ankylosed mid to upper lumbar disc spaces with significant coronal deformity, I'll consider lateral or consider T-lift. And I want to shift gears for one more minute and kind of just highlight some of the things with the SMIO platform, because I know Greg has done a few SMIO cases at Scripps. And so again, this is a platform I've been working with probably for over 3 years as they prepare to commercialize here in America. So I've been working with the Rusoli team for a bit, kind of with their software and sort of the deliverable here in the United States. I kind of won't get into this. And, you know, they have their own proprietary posted screw system, which again is kind of reflective of systems of the past that Dr. Ekbarnia had helped develop and use throughout his career. And so we're using something again with these, and I won't get too much into that. That can require a whole talk all on its own. But the nice thing about this is similar to using SurgiMap. Once we upload pictures, you as a surgeon can systematically go through each disc space or each vertebra and plan a correction, which you can't really do with, you know, the unit platform. So you're able to go in and do modeling on your own in terms of the sagittal and coronal correction. There'll be a little scale on the bottom. You can slide it to see what it looks like to get what degree of coronal correction. You can also have the SMIO crew come up with a corrective strategy, which will get sort of the key parameters back into an ideal position. And so this is a Schurman's case that I'm currently planning. And so this is kind of what the crew had planned, and I volleyed a couple plans back and forth with them in terms of instrumented levels and so forth. And this is kind of what the plan was here. And so like this was given the patient's sacral slope and pelvic incidence. If it's a very low pelvic incidence and shallow sacral slope, you know, pre-op they were an anteverted type 3, and this is to actually convert them back into a Rusoli type 1 spinal morphology. And then the nice thing about this is they'll give you benchmark cases. So they'll look within their database, match this patient to a patient with a similar deformity, and kind of show you the pre-op to the post-operative outcomes with patients. And this will come, I usually get like 2 patients per case. And so we'll get that. And then, you know, with this, you'll also end up getting a rod. You can get a rod template, you can get a prevent rod. And, you know, again, it's pretty easy to interface with the planning team through the app, or I just, you know, text my engineer and, you know, we work things out that way. This was a case I just did recently. It was a lanky 1BN, lady with a 60-degree curve, and using actually the posted screw system, getting her pretty much straightened out. It was a really efficient case. And these are titanium rods. And typically with the AAS cases, I've always done sort of a leaf spring technique. And I found that, I guess because of the way their titanium alloy is, you know, even with a titanium rod in a deformity, there wasn't really a lot of metal deflection. You know, you didn't see the rod bending under stress in the OR, and this gal straightened out really nicely. And it was a very efficient case. So like the few cases I've done with sort of the posted screw system at this point and using their rods, I've been really satisfied with, and I've really found a lot of benefit in working with their software. Okay, so in summary, you know, through data collection, machine learning, a continuous cycle of improvement is created through database enrichment. Predictive analytic can model reciprocal changes with various treatment plans and help to mitigate untoward complications such as PJK, rod fracture, and revision rates. And patient-specific implants serve as the guardrails of successful correction. And now, as I said, you know, one of the things, I'm a professor of the kinetics of kindness, And I'm gonna just take a little second here because this is just full of stoke. So this is my friend Dave. You've probably worked with him. He works with SI Bone. He's an amazing human. I've known him for about 20 years. Anyway, probably about a few months ago, he called me up and he's like, hey, Blaz, I know you do adaptive surfing and I met this kid. Do you know this guy? I'm like, yeah, I've been to Hawaii with him a few times. And he goes, I'd love to be involved. So I hit Dave up for a few occasions and I implored Dave to come get his big wave risk assessment group sort of lifeguard certification with me, which he did. And then he's gone on to be a waterman for numerous events. This was an event we held in Waco, Texas, where Dave came, gave up his time to come and help these athletes have an amazing time. This was at the ISA Worlds up in Huntington Beach a few weeks ago. Dave came up, he was water safety waterman there. So just all around amazing human. Dave calls me up and he's there like, hey, Blaz, I met this guy. He crashed his power wheelchair into my e-bike, knocked it over, and then his wheelchair died. And I pushed him up the hill back to his care facility. So this guy's pretty amazing. This is Jeff Rose. He has Friedreich's ataxia, which is a progressive neurologic disorder, which basically eats away at your nervous system. So a lot of people end up, with very bad ataxia of like all muscles in their body, problems swallowing and so forth. And it's kind of a form of a locked-in syndrome. I know, our neurosurgery colleagues on the call are probably familiar with that, where you have a fully functioning brain, but you're unable to use your body. And in that, it's progressive. This kind of came on to him in his mid-20s, and now he's in his 40s, and he's in a care facility. So Dave met this guy, and he said, Blaz, I want to take this guy surfing. Can you take him surfing? And so through my connections within the adaptive surf world, we set up a surf camp for this guy this past weekend, and we got him in the water and got him out surfing. And so this is a guy, you don't really know how much longer they're going to live, but like with Dave and another waterman, Jeff Easter and Chaka Webb from Stoke for Life were able to get him out and give him a really amazing day. And here he is afterwards. I mean, he's just a tremendous human, and he's got like such a great team that cares for him, a lot of friends that are really compassionate about him. So, I just want to give a shout out to Stoke for Life and Dave Reevely for just being amazing humans and really being part of the whole kinetics of kindness. And if anybody ever wants to get involved, Stoke for Life, it's a local organization and out of Oceanside, and it's really engineered towards getting athletes back in the water and having experiences. And so I just want to say thank you, and I'll open it up to questions from the trainees.
That was awesome, Blaz. Thanks, bud.
Yeah, gladly.
Yeah, thanks, Don.
I'm gonna end my slideshow.
What do you say to you're spending a ton of money per case, and what do you say to the financial piece?
I think it comes down to the outcomes. I mean, Greg, we've been doing this for 15 years now, and historically we've been challenged, and I think you and I are both at the points in our career where we're getting better outcomes, and we're seeing better outcomes through the use of these technologies. After we got sort of our first wave of information back from the Compass study, I actually presented to the Senate this past summer for extension of the NTAP. So things like that, we've got an extension for to use this unique medical technology. In terms of the rods and so forth, it's easy for someone on the value analysis committee to say, well, it's just a rod. These other rods cost this and that cost that. But you're not really just buying the rod, you're buying the service, right? You're buying a plan. And historically, we've not been good at planning as much as we've sat with our surge maps, and this is where we want to put it, and this is what we want to do. The actual execution of it, we haven't been great at. And and then again, we just sort of look to our leaders. Dr. Lenke was on a few weeks ago presenting his stuff. Larry's been championing the patient-specific rods for a number of years now, and this was a guy who was probably staunchly adamant that he would never need this before. Now he sees the value in it. So I think we step away from the dollar and cents end of it and think that we're treating a human. And I know a lot of times the insurance companies only care about that 90-day episode, but in the deformity world, we don't get rid of them after 90 days. We're married to that patient really for our career. And if we're preventing return to the OR for failures and rod fractures, then I think we're doing our patients right. And I think we as surgeons need to advocate for technology so we can get them into our systems. And I know when the young guys come out, it's always a challenge. And usually within, probably, these various companies, there's someone that can help you gather information to present to your value analysis committee.
Yeah, we did the Aprivo thing here, and the value analysis committee basically shut it down. That was
well, Greg, that's not true. But we can talk about it more offline.
Yeah,
case by case basis.
I'm not saying good or bad, Jamie. I'm not saying it's the wrong thing. I'm just saying it's a huge responsibility. And if the system that's adopting the technology is not able to make good on things like the NTAP, then it doesn't make sense, right? Because it's a huge money loser. So it goes beyond that. I mean, the whole system had to change basically not change, but had to adapt, and our system had a hard time adapting.
Well, again, we can talk about it more in detail if you want more details about that. But I don't think they had any problems doing that when it was appropriate to use for the cases.
Yeah, but like to get the approval to use it was troubling, because we weren't getting the NTAP. Was my understanding.
No, and maybe for a select couple cases, we can talk about that more offline. Let's talk about that more offline.
Dr. Blaskiewicz, it's Yusuf, one of the fellows. Do you ever find any challenges, kind of using these different platforms together, such as when you're using like a SMIO planning system, maybe with a unit rod with like, the Aprivo implants? Do you ever find challenges in combining those into one unified plan?
Initially, I think there were some barriers to getting the plans to talk. But there's so many of us in the deformity world that are using both the rods and the interbodies that once you get sort of the two different engineering teams to communicate, I think what it comes down to is what plan you use is the initial driver. With the rods, at least the unit rods, it's sort of a sagittal correction that's being planned. Whereas with Carlsmed, it's because it's based off of CT, so you have like a three-dimensional plan. So I think a lot of folks were doing, the rod plan first, and then having the Carlsmed folks fill in the plan relative to what unit had come up with. I've kind of done the reverse as of lately, and I think a bunch of us within the Compass study are doing that now as well, is using the Aprivo plan to drive the unit plan. But to me, it's been, pretty seamless, to get these two platforms to communicate with each other. Ultimately, it's just you end up on a, de-identified email or text with engineers. So.
Hi. Dr. Blaskiewicz, thanks for a great talk. Having now used both posted and polyaxial systems, what would you say is the case that you would use a more standard or classically used polyaxial system over the SMIO at this point?
Yeah, in fairness, I've only done 2 SMIO cases. I haven't done a sacral plate or pelvic fixation yet. I think with the AIS cases, I really like using the Chiron posted system. Mentally, I'm kind of trying to get my brain wrapped around sort of that more medialization of the rod, giving up territory for fusion mass, with the way the posted screw system works. I even, talked to Greg, kind of offline about like, oh, wouldn't it be great if you could put this laterally? So I think, I'm very cautiously beginning to do cases with it. I think, I've grown up in the era of, standard pedicle screws with various heads, whether it be poly, deformity, mono, unis, or fixed heads. So like, once you're accustomed to sort of that workflow, you have to reconfigure what you do in the OR, I guess, to kind of do this. I guess with the posted system, you could do temporary rods and things like that. And I guess probably next year when I give this talk, I'll have a little bit more information on it. But it's been a cautious kind of inching out onto the ice with this, just so I can be comfortable with what it's doing rather than getting into a case and feeling like, I'm a little bit over my head with trying to use this with sort of the degree of complexity that I see in my practice.
How's it do in the sagittal plane, Don? I mean, is it more challenging in the sagittal plane?
I think it, in the few cases I've done, it hasn't been. And again, the cases I've done are AIS cases. I've looked at what the Europeans are doing with it, and they're finding that in the sagittal plane, it's really effective. When I look at the cases that they've been presenting, and even with things like spondies, because of the way the system is posted, you can actually use that to reduce your spondee. And again, like, I'm picking away at the chip shot cases right now with the AIS, and little by little I'll be doing bigger cases.
But they're monoplanar, right? So
Yeah.
sagittal plane, if your screws are off plane relative to the vertebra,
Yeah.
that creates a malalignment problem, right?
It does. And
Carrier
that
mechanism.
Yeah, with placing these, you really have to be parallel to the end plate, and then the rod is planned to fit within those, clips, with it being parallel to the end plate. And I found for me, I use 7D on all of these, and just planning the screws on the workstation such that that's the trajectory I'm taking has been helpful. And again, as I start to get a higher end of these, I'll be able to give a little bit more back.
It'd be interesting to know if
I think
the guys using it are. Go ahead, Greg. Sorry.
Yeah, I was just saying, like, so many of our cases are revision cases, and that's where I've, like, you got to really think through that if you want to use that system, because you didn't put those screws in to begin with. And if you got, sometimes, especially like some of the robotic revisions that we do are actually really good because the robot will put the screws in really consistently. And that's actually really good for revision, versus someone that, maybe freehanded it and the screws are a little bit all over the place. It just doesn't work. They do have offset connector. They have like these offset connectors, but they're not good. So you're best just not using them or skipping the screw. And that's kind of what I found is like a lot of times you have to skip the screw.
I wonder if the guys using the system more plentifully are doing freehand. Because I would think that, I mean, if you're 5 degrees off relative to your vertebral end plate with a monoaxial screw design relative to the rod, you're going to create some stresses that may be undesirable, right?
Yeah, so I've done, I think 3 freehand now. And you just, instead of, I usually go pretty fast with screws, I'm just slowing down a hair. Because I'm just making sure that every head lines up appropriately. We did an AIS the other day, and I ended up taking one screw out and adding it somewhere else because the screw trajectory was off, and I tried to redo it and it just wasn't right. So I just went to another site because I was skipping screws on the convexity anyways. But it would be a real problem if you're at a critical screw. So I think it's much better with nav.
All right. Thanks, Don.
Yeah. Thanks, guys. Really appreciate it. All right. See you, everybody.
Thanks for all the work you do, Don.
Yeah.
Thank you.
Thank you, guys. Love you guys. Bye.